Good day, everybody. This is Kat from Cats About Town. Today we are talking to Steve Pelletier, Dr. Steve Pelletier for most of us, Steve Pelletier for some of us who have known him for many years, like our producer, Stéphanie. Steve and his colleagues are the ones who set up this wonderful Clarence Rockland Family Health Center. There's some marvelous things that are happening in here, on the leading edge of medical administration, trying to make healthcare more affordable and more accessible for all of us. So this is going to be quite an interesting and revealing interview for those of you, those few of you possibly by now, who are not patients at this clinic. So with that, I'd like to introduce Steve Pelletier.
Thank you.
Thank you very much for this interview. We've taken up a lot of your time already with setting everything up. It's quite the clinic that you have here and quite the history. Would you care to tell us a little bit about what brought you to this area and what brought you to build this clinic?
How it started and
how it
a little
started,
bit behind
yeah.
it. This particular clinic has been here now. I was actually calculating about 8.5 years that we moved into this this building. The doctors, the core of 8 or 9 doctors when this started had been doctors in the area for quite a long time. These were physicians that were dedicated to kind of Clarence Rockland. I was in Clarence Creek with a few colleagues, and there was a group in Rockland. And we'd been working relatively autonomously. We knew each other. We were very collegial, but we didn't really work together. And at some point we realized it was probably made a lot of sense. We're not that large a community, an area, to probably pool our resources, our knowledge, our skills, and get together to improve the level of service that we were giving. It was also the time that at that time we were using paper charts, and computer charts were becoming available, and we saw the advantage that would give us in terms of efficiencies, in terms of patient care, reducing errors, things like that. So all that together, we sat down, we talked for about 6 months or a year, and decided that we would create one clinic with all of us. So as I say, there was a core of, if I recall, 8 or 9 physicians who'd been here for a long time, so they were already committed to the community. And during that time, I met a person who's still with us, Harry Jones. He's not a physician, but he'd been working in the hospital setting, and I'd known Harry for a while. And one day, I don't think it was over breakfast when we were just having a meeting, he said, we have to do something different. We have to stop people going to hospitals if they don't need to. And he said, there's too much emphasis on hospitals. I mean, hospitals are necessary, but if we could early on treat people in their own community, manage more there so that they're not having to use the hospitals, this would be a good thing. And he says, I've thought about maybe, a new model, maybe in Ottawa or something. I said, Harry, your timing couldn't be better, because we're thinking right here to do something different. We'd like to tackle that. So we got Harry involved, and we put together a plan. And the 3 things at that time that we realized that we really had to concentrate on were, one, we had to get very good technology to support us. We had to get the right people working for us, people motivated, who shared in the vision, and I'm talking all employees included, and a proper building. And I'd never realized until we moved in here how much well-designed space adds to patient care and efficiencies. So it was a busy time. It took about 2.5 years to get everything together. The building was custom designed to our needs. Although that was a bigger project than moving into an existing building, it gave us an element of freedom that we wouldn't have had if we were trying to retrofit or fit into an already existing place. So we worked with architects, designers, and put a lot of our input. I had my white hat. I was here every day when the construction was going up. I'm sure I was in their way, but it didn't matter. We wanted to make sure to get it right. And then we moved in 8.5 years ago. We built it for future capacity, so today we've gone from 8 doctors to now it will be 15 shortly, and probably close to over 40 people working here with all kinds of different skills.
Well, definitely it's been a long-held tenet that people went, back in the days, that people went to the hospitals to die, not to get better, because there were so many germs everywhere. And although that's not as bad these days, but you still go to a hospital and you feel like it's dirty, and that you are going to come out of there with something you didn't go in with.
Yeah, it's
Not here.
No, no. Yeah. We're actually, when you walked in, you probably saw we're repainting, so it's going to look very new
No, I
within
didn't
about 2
notice
weeks.
that.
Yeah,
I just noticed it was airy and fresh.
yeah, yeah. So yeah, the couple of things we did, we spent a little more money on the ventilation system. We wanted a more rapid air. I'm not an expert on it, but I don't know how many times per hour the air gets exchanged. We decided that that was important for us. A lot of natural light, so we've got big windows, these kinds of things. We wanted people to feel good when they stepped in here. The hospital is has always been seen as kind of the pinnacle of healthcare, but and to a large extent, what hospitals offer, hospitals need to offer. Surgery, these kinds of things. They have to be in very controlled environments. But there's a lot of, in my opinion anyway, there's a lot that could be done and should be done out in the community, outside of hospitals. Big, huge hospitals that offer clinics for all kinds of things. I'm not sure it's the right model for the future. I think a more distributed kind of healthcare would probably serve needs better, and so it's one of the. I mean, one of our ideas here was to, one-stop shop kind of thing as much as possible. I mean, you can get to a point where there's services we can't provide here. But also when we had the building put up, we made sure we had enough space for the allied services that we need, labs, x-rays, that physiotherapy. We've got various other things so that, when people come here, when they leave, it's all done. They don't have to drive all over the place. And so that was part of what we...
That's a big advantage.
Yeah.
You certainly want to keep people off the roads as much as possible these days.
Yeah.
We already have a serious problem with traffic around here.
Absolutely, and people are busy,
And they're busy,
yeah.
and it's stressful, and anything you can do really to minimize stress, because that's all part of healthcare.
Absolutely.
So I've been to a few clinics, luckily never for myself. I've enjoyed wonderful health, but I do remember one evening I spent in a clinic in Orleans with a little girl. She was at the time 4 years old, and she had an earache. And we were sitting on the floor, and there were crowds everywhere. It was dreadful. It was dreadful for hours and hours. And you've somehow found a way to get around that. No need for that, it seems, to spend hours and hours waiting.
Yeah, I think a lot of the traditional ways of scheduling, of managing patient flow, I don't think they serve anybody very well. And so one of our objectives was that, my ideal, I can't say that I'm there yet, but I'd like someone to be able to move to Clarence Rockland, pick up the phone and say, we're just new here, can we have a doctor? Yes, absolutely. I'd like to be able to answer that every time the phone's picked up. When would you like to meet them? Not, let them pick the time, and then when they come in, they get served when they come in. I mean, I kind of expect that anywhere I go, so why wouldn't they expect it here? So that's always, when we meet and talk, is this where we're going, what we can do for that? So we experimented with many different ways of scheduling, and right now we're pretty close to where it should be. We've managed to take out a lot of the steps, what I call the speed bumps that occur in the scheduling and the patient flow. So one of our objectives is that people don't wait more than 10 minutes from their appointment. So we monitor that. I can't say we are at 100%, but we're doing quite well. We don't have to do...
Well, you're in a francophone area. Then we talk around here. Yeah. On aime jaser.
Yeah. And it's, because it's healthcare, occasionally there's emergencies and that happens. But people, because they're normally served at the time that they expected to be served, if one time they're not, they totally understand. They know that it's unusual, so there must be reason. So they're very, our people are very good to us, our patients, so they understand that. So yeah, it sounds like a simple thing. It's not that simple to do, but it's always what we're trying to work for. And, people are already, when they come here, they're worried, they're concerned. They may not all be sick, but they're worried about something. You don't come here for a social call.
For coffee,
you come here, exactly. So anything we can do to relieve some of that worry, so, by being able to serve you on time, not, looking at your watch, and because you've got an appointment, you're going to be here an hour, 2 hours, I find that inexcusable, honestly, today. I'm surprised society tolerates that in healthcare.
They feel they have no choice.
Yeah, that's right.
And I think that that's something that has always marked the medical profession, that doctors are gods and the rest
Yeah.
of us have to just
We call the
kowtow to
shots,
their
and
wishes.
yeah, that's right. And
Yes, so we're
that-
going to keep calling you Steve, just to make sure
Perfect,
that we
yeah.
dispel that myth.
yeah, and I mean, I'm talking on behalf of all my colleagues. We're all in the same wavelength on this. We spend a lot of time. We worry about being able to meet that. So I'm very fortunate to be with a very good group of people, and we've really got, at this point, we've got a meeting of the minds on that. Our vision is pretty close, all of us together. So that helps, you know. And so people are always looking for ideas. Our employees also. I mean, they'll, you know, we try and foster an environment where people, if they've got some ideas, like bring them. Let's try it. If it doesn't work, it doesn't work. But we're not afraid of trying things. And employees, because they're the frontline people, they've given us a tremendous amount of very useful information and ideas. So it's really great.
That's quite an achievement for 15 physicians, a staff of 40, to be able to achieve that kind of
Yeah, we're
harmony.
fairly cohesive. Yeah,
That says a lot.
yeah.
Now, just to be clear here, because after hearing even this much of the interview, people are going to say, hey, I want to be there. You don't take walk-ins.
It depends how you want to define a walk-in. If someone presents at the front and needs help, we will help them. But the problem with walk-ins is that if we just allow people to either call or walk in, our wait time, our objective of a 10-minute wait time maximum will fall apart. If you call and you say, I want an appointment next Monday afternoon, and you say we'll come in at 3, you will, after a while, expect to be seen, that you'll be seen around 3-ish. If I don't manage the flow of patients in, you could be seen at 4 or 5 if we allowed walk-ins, and we're trying to avoid that. So what we've done instead is we've scheduled in a way that allows a huge amount of same-day appointments, but we ask people to call so we can manage the flow to be respectful for the others. So I consider that a form of walk-in, but if you can give us a contact, you know, if you say, look, can I be seen today around 2, and we say, look, how about 3:10? You might say that's fine. Most people have that flexibility, but at least then you'll be seen, or potentially be seen at the right time, and will not be in the way of others that have made their appointments. So that's how we decided to do it, because the walk-in, where you just walk in and wait for your turn, our wait times will start decreasing again. And you know, I don't like to keep people waiting, but I feel as stressed as they are. When I do fall behind, it bothers me, I think, more than it bothers my patients. So I don't like to work that way when I know someone's waited so long to see me.
I can believe that, yeah. Well, I'm sure that people would be more than happy to be able to call an emergency department at a hospital and say, when can you give me a time? I'm going to wait at home rather than wait there.
I don't know why they don't do that. I mean, these are things...
Are you listening?
Yeah, yeah.
Somebody?
No, there are, you have to kind of take it apart a bit and then rebuild it and try some things. There are all kinds of very imaginative ways of scheduling that work, some less well, but anyway, so that's the answer to the walk-in is that.
Yeah.
The other thing too is, as our vision is to meet the needs of Clarence-Rockland and surrounding. I mean, we haven't really drawn an exact line, but for that reason, we don't, at the moment, we're not looking for patients outside that circle, because if we do, it will saturate our capacity, and then, you know, new families, Rockland is growing in leaps and bounds, new families who come here might not be able to access the clinic, and I can't fix the whole primary healthcare system, but we're going to try and fix it for Clarence-Rockland. I mean, that's a bite I think we can handle. So to do that, you know, we have to turn down patients who maybe come from the west end of town who are looking for a doctor, because until the day we're satisfied that we've met all the need here and we have extra capacity, then we'll enlarge the circle. But at the moment, we're keeping it a little tight, and again, because our commitment, our promise was to Clarence-Rockland and vicinity, you know, the neighboring areas. Yeah.
I have a feeling that Clarence-Rockland felt suddenly very grown up, having a clinic that looked so sophisticated.
It's a nice building. Eh?
It's a beautiful building.
Yeah, we're pretty happy with it. Yeah.
And the manor next door, that's a beautiful thing too. The gas station,
Yeah,
we
it's
need
convenient.
it.
Yeah.
Yeah.
Yeah, we're happy, and it's. I think it's nice for patients. It's nice for us too. It's really a nice place to work. We
So important.
Yeah, we put in a few, I call creature comforts. Our hallways, instead of being the standard 4 feet wide, are 5 feet wide. So, you know, if you're crossing paths with people, you're not rubbing shoulders. Different colors. I mean, it costs nothing to just add a little bit of niceness to it. And so I think, we want patients to feel good, but we want the people working to feel good. And, I know we all like coming to work here.
Well, that's a great thing. That's a great thing. Well, we're going to break now for a pause because we have sponsors also. We're going to come back and find out a little bit more about visions and visionaries and how you keep going in a complex world such as the healthcare system, coming up against all of the obstacles that you're bound to run into, like we always do in life. Obviously, you had an idea whose time had come, with all of the people just falling into place to help you out. But visions and dreams and great ideas sometimes have a really hard time getting off the ground, no matter how good they are. You managed to pull together a few funders and interests and associates and partners, which could be very interesting to hear. How did you approach them with the idea?
Well, initially it was really with the physicians who were in the community. It was clear that that's where it had to start. That had to be the core. When we put together a plan, we realized, if you're talking about funding, clearly this doesn't just grow out of the ground. Yeah, we had to look at all those aspects. But physicians, I think a lot of people understand that remuneration that we receive, part of it is to pay for expenses. So we're accustomed to paying for certain expenses. So it was a matter, as a group, we have a larger pool of money, clearly compared to a solo or one or two physician practice. So with that, we prepared budgets, we looked at that. And at the time that we were interested in doing that, there's a program that started in Ontario. They're called family health teams. And these were competitive programs. We had to apply and compete to be recognized as a family health team. So what it is it allows us to access certain resources, funds, in exchange for certain promises we make, certain objectives that we have to meet. So every year I won't say we reapply, but we tell them, look for if we can have funding for maybe these types of allied health professionals, if we can have a dietitian, a kinesiologist. So they will cover that salary. And in exchange, we guarantee we have objectives that we'll meet, and they look at it and they say that's in line with what we would like to do to improve healthcare, to improve access and things like that. So this came out at the same time that we were thinking of pooling our resources as physicians. So with that and with with family health team funding and with physician funding, now it became kind of, it kind of made sense. We could see that this might just work. The money was there to be able to do this. When the community heard about it, you can well imagine everybody was on board. And at that time, Société du Moulin was a fundraising group in Clarence-Rockland that had been involved in fundraising for the community for various projects. I can't remember what they did, but I think they were involved with certain parks and things to do fundraising. So they approached me and said, can we help? So, and they were able to fill in a gap that we weren't quite sure how we were going to fill. As family doctors, we have certain expectations that we pay salary, we pay rent, as normal business people do. But because we wanted to increase or improve the level of service here, there were certain equipment, fairly expensive equipment, that we wanted on site. And we couldn't really convince the government, because normally these equipments would be in hospital surroundings. So they said that's not, we don't really see that as a primary care tool, and you can still access it if you send the patient to hospital, and we're trying not to send patients to hospital.
Sounds like a very bureaucratic answer.
Yeah. So Société du Moulin stepped in. So we had, at that time, we were quite interested in doing cardiovascular disease management, testing, prevention. So they bought for the clinic certain types of monitors, specialized equipment, many tens of thousands of dollars that they went and gave to the clinic. Didn't give to us, it gave to the community, but it's housed here. So it means that, for instance, Holter monitor that measures heartbeats for 24 or 48 hours if someone is having a problem we're concerned about. We strap on the machine here, they go home for 2 days and drop it off here. They don't have to drive downtown, whatever. So and then we've organized electronic link with a cardiologist who interprets it for us. So and then we get a very rapid turnaround. So this was very helpful. So we had a community, it's nothing I wouldn't have expected to have a modern facility. They jumped right in. So with all that, I think, and with budgeting and negotiating and that sort of thing, it all of a sudden made a lot of sense, and it was very financially doable.
So was it ever, I guess it's not really a concern for patients, but was it ever a factor in these funding schemes that you are saving wear and tear on roads from having people not go to hospitals and driving in and increasing risk of accident? Are all those things taken into consideration?
Yeah.
They should be.
They should be. They really should be. It's interesting you say that because, if you look at, if a test can be done here where someone lives, often in the evening instead of daytime hours, because we are open evenings, so someone can come in and get their Holter monitor at 7 o'clock. They haven't missed work. They've not had to travel back and forth to work because it was midday, and then drop it off in 2 days later. Just the productivity from the patient's perspective, from their employer's perspective. I mean, I think it's tremendous. I'm not sure it's ever been calculated, but the amount of productivity loss simply because of scheduling, non-local availability of things. I mean, I think you're absolutely right that I think it would be staggering if we were to see how much waste there is, not wasted healthcare, but waste there is in time, and time translates into productivity and money. So.
Oh, absolutely. Well, in fact, you were telling me earlier about how you are moving more and more towards the option of being able to give telephone consultations because of the payment plan that you have, which is, my goodness, it seems like it's revolutionary, and yet...
Yet the rest of the world works this way, yeah.
Yeah.
I mean, sometimes it may sound a little harsh with healthcare to say that it's behind. It's true. I guess the harshness is because we compare it to maybe other environments. We have fairly strict, very strict rules in terms of privacy, confidentiality. So anything we do when we interact with people, we have to be sure that it cannot be listened in on, seen by other people. So that puts us at a level that I think is as high as anywhere in terms of, so that makes it more difficult for us. But at the same time, I guess the most private encounter would be in a room, an examination room, soundproof examination room, when you talk. But there are all kinds of other ways of, providing services. When you talked about phone, the reality is that in many cases, I don't necessarily need to be in front of somebody to be able to help them if they've sometimes simply some questions. It may be someone who's been prescribed a medication, they're not sure about a side effect, something's new, they're not sure what to do. To have them leave work at 1 in the afternoon, come down, get into my room, and then we talk for a few minutes. And sometimes it could be simply saying, oh yes, we know about this, I'm sorry I forgot to tell you, but it will go away in a few days. That just seems like a real waste of everybody's time. So I'm trying to do more and more. If we can identify the encounters, if we want to call them encounters, be they phone or maybe Skype in the future, whatever. There's all kinds of things open. Then we might be able to save a lot of patient time, save my time, because as the longest encounter is when you have to come in, sign in, that sort of thing. All that is. And as long as we do it in a secure and private fashion, then I think there's a whole opportunity to provide a more efficient service. And what that does for us is it increases our capacity. So when new people move in here, we can say, yes, we do have room in the schedule because we've managed to. So I do on average 15, 16, 17 telephone encounters a week. I say for my practice, receive about 15 to 18. Sometimes I'll ask the nurses to call because they're quite good. I'll say, look, could you handle this? Because someone has a question about, they're 1 month old, he's got a bit of fever, not sure how much Tylenol to give. Shouldn't really need an appointment. If they're worried, obviously we offer an appointment. We don't want to put anyone at risk, but nurses handle that. So again, it frees up my schedule. So So yeah, I think these are ways in our remuneration system supports us doing that. We're not penalized in the way we are paid here by doing that. So that's fairly unique to Ontario, and I really think that this is the future.
Well, absolutely. And not only is that the future, because obviously our healthcare system is pretty unhealthy.
Yeah.
And too many people are not going for healthcare because it's too complicated to get it, or not going for healthcare because they really don't know what to ask for.
Or they don't know where to go. They have nowhere to go sometimes.
Or they don't, or they have nowhere to go because their option is to go sit in a clinic with a lot of sick people, and they don't want to do that, or go sit in an emergency room and wait, as we were talking about earlier. But the other component, of course, is health promotion, not just health care. And is that something that's part of the practice here?
Yeah. We really believe that a patient has to be a partner in his own healthcare, and our patients really have moved that way. I mean, hats off to all people, because I think they really realize that, and we see it now more and more. I mean, we've a lot of our allied health professionals that are funded through the Family Health Team program. We change our programs on a fairly regular basis based on need, but for several years we had cardiovascular risk factor management. So what we did, we started with patients who had 3 or more risk factors for heart disease, identified them, and our technology allows us to identify them fairly easily. And then we offered them interventions, teaching, meeting dietitians, exercise counselors, these kinds of things. So, and then when we did that for a while, then we rotate things based on the need. If we hear that a lot of our patients are going to emergency, a lot of our asthmatic patients are going to emergency, we go, okay, we have to step in because we should be able to prevent that from happening. So then we will change our direction. We're fairly nimble, so we can, and it's at our discretion. So then we may say, look, for 6 months we're going to tackle our asthmatics. We're going to get all the ones that went to emergency, bring them in. What happened? What can we do to make sure? And this is what you'll do next time to avoid that trip. So we've seen significant changes with that. I mean, even something as simple as managing the common cold. I mean, we early on we said, look, patients should understand that the common cold, there's not much I can do for it. It's a virus, and here are the signs. And we told patients, when that happens, this is what we think you should do. If you're worried, come in. We won't refuse anybody. But why don't you try this for a while? And this is what you can expect. And if it goes like this, probably don't need to come in. So we see less and less people with colds here.
Because they know that somebody cares and will do something about it.
And if we're available quickly, that if they go, look, things are not turning the way, and I'm worried, we'll say, yeah, well, come on in today. We'll check it out. So this works well. So it's really working with patients, and we're fortunate our community has responded really, really well to that. So we don't see people with colds, or people will come in and they go, I've got a cold, I'm sorry I'm in, I've had a cold for a week, and I'm saying, you don't have to apologize if you've had it for a week. I said, I want to see you. Let's just make sure it's nothing else, So, but you can see that they're helping themselves. That decongests our schedule here. And but to do that, you have to be able to promise them that when they do get worried, you'll be able to see them in a timely fashion. So, and that's what we have. That's what we worked on. That's the trade.
Well, these days, with all of the medications that are being promoted and pushed on us, and everybody thinks that there's a magic pill for everything. And if you're still sick, it's because you haven't found it, and who knows it better but the doctor. And I think it takes the doctor's reassurance to tell them, no, it's probably your body.
Yeah.
If it's healthy, that's your best medication.
Yeah, and I find, at least in my practice, people respond very well to that. They go, so it'll go in its own? Yeah, I'm pretty sure.
Yeah.
But if it doesn't, buy whatever, give me a shout. And so it's really working with the person. And so we're trying to, we've reduced, I think our prescription rate is quite low compared to a lot of places, because we, if things don't go well, we'll reassess, and if at some point you need something, we'll step in and help. But it works well, and it's very satisfying professionally to work that way. It doesn't feel like just a treadmill here. It just
Well, I have a friend who is a physician. She graduated recently, and her first posting was in Sydney, Nova Scotia, and she had the dreadful experience there of taking over a practice and finding so many people on narcotics.
Oh yeah.
So many of them. And she had to fight with them because they insisted that they had to continue these. And she
Right.
insisted that, no, they were making themselves sicker.
Yeah.
So that kind of re-education is so painful and yet so
Right.
important, because the
Yeah.
last thing you want to do is make your patients sicker.
Yeah, and it's one thing we do here. The docs, we meet on at least monthly, sometimes more often, and we'll we'll look at certain conditions and try and standardize as much as possible how we will manage the condition, so that patients in the whole group will be getting the same kind of advice, same kind of management, so that if one day I'm on holidays and they see one of my colleagues for that condition, they won't be told a whole different story. Mm-hmm. So standardization has been really good, and we usually come pretty close. I mean, each physician practices their own way, but at the end of the day, the common conditions, we go, okay, in a case like this, we agree that this is what we would do, this is what we'll prescribe if it's needed, so that things are, and then, so it'll be very easy for, the day I retire, someone takes over my practice, they will hopefully fit into a practice that is, again, in a standardized fashion with the rest of the group. So that's important for us. And also we're trying to provide whatever the latest advice is, whatever the best standards are for these conditions. So.
Yes, that shouldn't be our biggest fear, is outliving our doctor, eh?
Yeah.
So we're going to break now, and we're going to come back and talk some more about the specific services that are provided here and how you can best take advantage of them and work with our community healthcare team. So here we are again. We're going to talk a little bit about, in the time that's left to us, about the services that you can receive from your healthcare team. Steve, if I had just been down south and I came back and I was worried that I had the Zika virus, for instance, should I come here? Would you say just go to the hospital? You don't have the equipment to test?
Oh no, we consider ourselves the first point of contact. I mean, if it's a very severe emergency, clearly go to the hospital. But for these kinds of things, I mean, that's not to say we can handle everything here, but I think we can facilitate it being handled if you were to come here. So if you had the Zika virus or thought you had the Zika virus, I mean, we'd have to talk about that, look what's recommended, and if there was significant reason to believe that you might have been exposed, then I might involve the public health unit. But we tell patients that we should be the first point of contact because we can facilitate as opposed to walking into an emergency room, and that could be a fairly unsatisfying experience for that kind of thing.
Okay. Now, how do you handle cases like, I don't even know with the Zika virus if it's contagious. It seems to me a virus is contagious, but how do you protect your staff and other patients from
getting sick?
Getting sick.
Yeah. So we're surprisingly not sick often here, and sometimes I scratch my head a lot and wonder why. I mean, I see probably in a full day 40 patients. I'll see them, and some people are quite sick from pneumonia, common cold, whatever. So we've got, we follow the recommendations, World Health Organization. We use the cleaning products that are recommended, and we've got protocols for all this. I'm not sure if you noticed when you walked in at the waiting room, but we've got, maybe on your way out, the receptionist, you'll see how the glass is set up. It still allows very easy communication. It doesn't feel like there's a barrier, but it's an excellent way to prevent transmission of particles.
So that's what it's for.
Yeah, so you'll see these glass panels. I mean, it's our third iteration. We finally found a place that had this and looked into it. So we had this done, I think, about 3-4 years ago, so that helps. We've got constantly someone cleaning in the facility. So we outsource that, but someone is here and is cleaning, and I got to wash my hands 65 times a day. I mean, we get into those habits, employees do also. So we're not that sick, surprisingly. I don't get sick very often.
All right. And sitting in the waiting room isn't a hazard to your health either.
Well, that's why we don't want people in the waiting room, and I hate that name, waiting room.
Oh yes.
Yeah,
I
call it my lobby.
For finding it a new name.
Yeah,
a lobby, sure.
Yeah, come on in and wait. But again, we've set up the chairs in a certain way to put enough physical distance between people. The material on the chairs is actually it's got a barrier to prevent contamination. So the material itself is specialized for healthcare facilities. Oh yeah. So your question's a good one. You have to think about it ahead of time, and but we've looked into that often. We look for. I guess our manager, Sue, is always walking around looking where there might be flaws or breaches or something, and we plug those holes as much as possible. So we're surprisingly healthy here, staff included. I mean, it's pretty unusual that someone's off sick.
Okay, so if I have a problem, let's say diabetes, I've had it for years, it's been diagnosed, it's not going away, but I want to, I'm tired of it. If I were to come in here, would there be a dietitian on hand, for instance, who could tell me this is the way you should handle it and monitor me and follow me?
Yeah, it's interesting you say diabetes. We're very, very aggressive at our diabetics. We believe that good control is important.
That's so many horrible side effects.
Yeah. And there's really good evidence that if you manage it early and fairly aggressively, you can do very, very well with diabetes and not really be a problem. So part of our allied health team has a dietitian. We've got a kinesiologist who will help people, especially people who might have some physical limitations but want to do exercise. She can help with that. We've got a team of psychologists, also called just social workers. Sometimes there's issues that they may need help with, sometimes adaptations at work because of their disease, these kinds of things. So there may be resources, a lot I don't know about, but there's all kinds of resources in the community, so they stay informed on that. They can help people deal with these things. We've got our nurses are very well trained. We send them for continuing education courses, these kinds of things. So I would venture, it's interesting you say diabetes, it may not be for every condition, but in our facility, if you're not well controlled, it's really, there's no reason not to be well controlled diabetic. And our referral rate out to endocrinologists is quite low because we can manage a lot here. Occasionally you run into someone who's got a very complex issue, problem, some that may be a little beyond our knowledge, but it's not that common. We can manage most of it here. So, and we've got a protocol. People know what to do, how often to come in. That's clearly set out for them. We don't wait for the problem. We're on top of it. So we try and do that with some of the more serious conditions, congestive heart failure, coronary artery disease. Someone who comes in who's identified that way, we say, look, this is best for you. I see you at this frequency. We do this at that, and based on best recommendations today. And we've got some very good specialist contacts that keep us informed on that and also help us out when we need help. So again, I think there's not a lot that I wouldn't say, don't start here first if you're a patient here. I mean, if you've got a bad injury and, clearly the hospital is appropriate place.
If I cut my finger off, I don't come here.
Severe chest pain, yeah.
Okay.
Yeah, like don't delay if you think you need emergency help. But even if you think it's a little complicated, start here and, maybe we'll be able to help, and if not, if we can't help with the condition, we'll help facilitate to make sure you get care in a timely fashion or as timely fashion as we can.
Okay. Do you have a philosophy, or yes, I suppose it would be a philosophy for the clinic, to use medication as a last resort?
Yeah, it's every physician's philosophy. I mean, all of us believe in the body's ability to heal itself.
Okay.
I mean, time is I prescribe time. I tell somebody, look, you'll be better in 2 weeks. That's what it's going to be, But we try not to. It's not unusual to prescribe a medication that causes a problem. Then it's tempting to prescribe a medication for the problem the first one caused. I mean, and especially in sometimes the elderly population who've run into some health issues start accumulating medication. Sometimes there's many doctors involved, many specialists, that sort of thing. So we do regular medication reviews, and most patients are quite happy to take less, not more. So sometimes we'll try, say, look, we're not sure we need this, why don't we stop it for, as long as it's not a risky thing. But sometimes we have no choice. Some people sometimes will need a different array of medication because of their condition, and we accept that.
Right. Wow, that's good to hear. So if I, for instance, if I'm a teenager and I've got a bad case of acne, then I will come in here and you're not going to start prescribing me with... We'll
talk about it. We'll start with the simpler things first and assess how much it bothers you, and knowing that probably a good chance you'll outgrow it over time. But sometimes if it's significant, you perceive it as a significant problem. It's not the way I perceive it that's important, it's how you would perceive it. And then, if I can get a sense of that, then we'll talk about the option. So,
Wow, good to hear.
So, no, not jumping on the prescription pad, no, I don't think none of the doctors do. We talk about that all the time in terms of trying to minimize, let the body, heal itself when it can.
Yeah, I love that adage about the physician entertains the patient until nature does its healing.
Exactly. Yeah, exactly.
But then you have to be pretty smart about the way you entertain them.
Yeah, I mean, we have a job. We don't want to miss things that need intervention quickly. I mean, that's always our worst nightmare. But as a rule, people are very reasonable. It's very easy to work with people. I mean, and people are accepting. If you say, look, I'm not sure what you've got. I don't think it's contagious. I don't think it's serious. But why don't we just see how it evolves? And often it goes away. Sometimes it doesn't. We chat again, and eventually we find it. And working with people like that, and people are I think they're quite happy about being dealt that way, rather than say, let's try this in case. Sometimes sitting back, as long as you're sure you don't have to intervene right away.
Right.
And that's kind of our philosophy.
So if I were to call here my very first time, would I be assigned to one particular physician? And then I see that physician all the time until that physician's away on holiday, then I see somebody else?
Correct.
Yeah.
So we're 15 physicians, and as we try and gain efficiencies, it increases our capacity. So we regularly, I say allow, I hate the word allow, but we will open the practice to take patients. One of the difficulties is if we leave it open all the time, it's hard to manage, because when say a new family calls, mother, father, a couple of children, they may have some health conditions. There'll be some time, the longest time required is up front to get the chart up to date, to manage what's going on, to deal with the current problems. So we tend to, accept, physicians will say, okay, I'll take about 100 patients, and then let me get those integrated in my practice. We meet them, and then another one will. So usually over the year, there's very frequently we allow patients to come in. And we do encourage people to be assigned to one physician. We'd like people to be able to name who their physician is. You're not, but at the same time, understanding that, if I'm not here on a Friday and you've got a rip-roaring tonsillitis, we will offer you someone else. They'll have full access to your chart, and they'll be happy to see you. So they'll give that support. If it's something complicated that's going to require a lot of follow-up, you'll probably be encouraged to return to me when I return, so that we can continue, so that it's a lot easier for me to practice if I know my practice, and I think most people prefer having their physician they know.
Yeah. Oh, they do, of course,
Yeah.
because you don't like to be telling the same stories over and over
Exactly.
again, especially for people with mental health issues, for instance. And that brings me to
any
the
condition,
that
yeah,
question.
absolutely.
Do you cover that too?
Yes, absolutely.
So you do have, you mentioned a psychologist.
Yeah, psychologist, social worker, and as a primary care physician, it's certainly part of our job.
True. Do you work in association with the Eastern Ontario Health Unit to?
Yeah, for public health issues,
Yeah.
we use them as a resource for certain things. When you mentioned the Zika virus, if we
Yeah.
really thought we had something, they'd be involved fairly
Well,
soon.
it seems like everybody is going
Yeah.
off to south from
Yeah.
around here.
Yeah, but yeah, we work with them. We've got the Arthritis Association that come once a month to help our patients. We've got different groups that come. We've got the
Alzheimer's, perhaps?
yeah. We've got a program right now on fall prevention for
Right.
elderly patients that might have some disabilities. So, and often will involve the local associations. Because we have a space, we offer space if they want to meet some of our patients. And so, this is kind of ongoing, and depending on the need, we try and respond.
So if there were to be house calls made, that would be the choice of the individual physician?
Yeah, and most do.
Yeah.
The house call is, it can be an incomplete kind of assessment, because we're so well equipped here. So if someone has a condition, let's say you say, look, I can't make it to the office, but I think I have a pneumonia. I may need an X-ray. I may need, it might not be as good a quality an interaction. So our preference is to be seen here, because we're so well equipped. If we need to do something, we can do it right away. But if people are immobile, absolutely, I think every physician will, see people at home if they have to.
Oh,
Sometimes we have to schedule a little bit, because the Clarence Rockland is not tiny. I mean, this goes right out to Bourget, which is, I think, about 20 kilometers away.
Yeah.
So I wouldn't do an emergency house call, because if just by the nature of it being an emergency, it's probably better not to waste time to wait for me. But if someone is immobile at home, then we may say, look, Wednesday afternoon I finish early, I'll swing by and we'll go through your medication review thing. That's quite appropriate. So we do some of those.
I'm glad you brought up the issue of emergencies, because many years ago I knew a young woman who was in the in med school at Ottawa U, and she decided that she wanted to be a dermatologist because there were very few emergency dermatology cases, and she really didn't want to be bothered in the middle of the night.
Yeah.
So for emergencies of that kind, people still have to go to the hospital, or is there an on-call?
Well, no, there's call service. There's always someone to answer. There's a nurse that calls first, the telephone health advisory service. So if you call here after hours, it automatically goes, and nurse can handle a surprising number of calls.
Yeah.
Because often they're fairly concrete.
Nurses need to hear that.
Yeah, no, they're... Nurses, I think, are often underutilized. I see nurses who, bring in patients and check their blood pressure. I mean, our nurses here don't even do blood pressure. We've got a machine that does that, and they'll do a lot of the education with patients, really helping to manage their condition. So I think that's far better use of their knowledge and skills. But
for emergencies?
Yeah, for emergencies. So we have a nurse who will do a screening, and then she has access to a doctor. So we each do a week of call. I just finished mine a few weeks ago. So, and the doctor on call will do an emergency clinic Saturdays also. And the nurse on call has access, not necessarily access to our schedule, but can tell a patient, look, I think you're okay. It's Sunday afternoon. Why don't you do this? But be seen tomorrow, and the patient can then come in and be seen. So that works well.
Everything that you're telling me paints a really encouraging and beautiful picture of a community health service.
Oh, thank you.
That really has seemed to permeate everything in the way you approach things.
Yeah, we're trying. It's and when we try something, the things we've talked about and they work, it's very encouraging to continue, because it's. I mean, I consider myself privileged, really fortunate to be working in a place like this, because it's very satisfying. So it's encouraging to keep trying and do more.
It is, and there's so much of this community that's so special, because it's old and established and small. And
yeah, it deserves a good medical clinic.
It deserves a good medical clinic, and it's also a beautiful way to promote all the benefits of being a community where. Obviously, there are a few taxi services that'll bring people in, and on the way they hear everything that their doctor said, and they can already diagnose them.
Right.
Deliver babies if necessary.
Yeah, exactly.
Has that ever happened here?
Not in this clinic. In my other clinic, it happened. Yeah.
You just never know
when
baby's ready.
Yeah, I don't think it happened here. But we have two doctors who do a lot of obstetrics. They're very good at it. One of the things, when we're 15, we all have kind of different interests within medicine. So, we have two who are very good with obstetrics. So if I have a pregnant patient that I'm following and I've got a few questions, well, I can go ask them. But then there's several docs I've worked in emergency rooms. So if someone comes in with a chest pain and we want a little help evaluating, so we act as resources to each other. So some people are interested in geriatrics, some people in pulmonary medicine. So we don't have specialists, but when you take an interest in something, you can get pretty good at it. And so we all know our skills. So every so often I'll go and say, can you just come and have a look here? Just, am I on the right track, do you think? And if they do, well, that's good. I think that's good for the patient. And I don't necessarily have to send to a specialist right away. So, and again, that's the advantage of a larger group. And it's a nice size, 15 docs, 40 employees. I mean, it sounds big. I suppose there's too big, but this is a really nice size.
Well, it is. And of course, we're sitting here in your boardroom, which is bright and airy and inviting, and I imagine there's probably a lot of interesting information that flies around this table.
Yeah, there is, and this is also used for group education for patients. So we offer that a lot of sessions. So diabetics, for instance, as long as people are comfortable being at a table with other people. So we ask them that first, but a lot of people are. So, or sometimes it's simply, good nutrition session, and, people come in, so we'll have 15, 18, 20 people here in the evening, and our dietitian will give those sessions. We do a lot of those.
Good to hear. What about addictions? Do you cover those?
Addiction, not so much. It's a more complicated condition. We've got resources in town or people that we work with for that, but to actually manage it from A to Z here is not something we feel comfortable handling at the moment.
Okay, well, there you go. You have a very clear vision and honest set of answers from your friendly Dr. Steve.
Thank you.
I want to thank you for this interview because I'm sure that a lot of people are still driving by this clinic wondering what goes on in here.
Right.
And not sure that the doors are open to them. But thanks to our producer, Stephanie, I decided that I was going to take the plunge and walk through those doors, and I'm really impressed with what I found. I think the whole environment of making health accessible and open and available to people is the first step in saving our healthcare system,
Right.
making people more aware of what it is that they have to do working with their doctors. So again, I congratulate you on your initiative here. I tip my hat to your courage because this is no small undertaking.
Well, thank you very much, and I appreciate your interest in it. I think nice message to get out.
And for those of you who are francophone, you must know that you can get all of these services in French as well.
Yeah, correct.
So thank you very much, Steve. All the best.
You're welcome.
And thank you to TVC 22 viewers, and I'll see you next week with another hopefully wonderful surprise of all the magical things happening in our community.